our next session, which is going to be AI in clinical practice from scribe to specialist, transforming patient care and clinician well-being. This session will be moderated by Janae Sharp, founder of the nonprofit The Sharp Index. Joining her is Toby Eadelman, the CTO at AvaSure, and Dr. Nick Patel, CEO and founder of Stealth Consulting. And now I'm going to bring them all on board and go on mute. And Janae, you can take it away.
Thank you. I'm thrilled to have this discussion today. So I'm Janae Sharp, and as healthcare organizations grapple with clinician burnout, increasing administrative burdens, tighter margins, AI technologies offer promising solutions to enhance patient care and clinician satisfaction. So I'm looking forward to sitting down with you both today and discussing things that are working. Like, we're ready for the good news, right? AI-powered tools from documentation to support virtual patient monitoring, they're really revolutionizing the care delivery and helping reduce burnout, improving clinical decision making, and addressing some of the staffing challenges. So if you want to introduce yourself to our audience, that would be great. We'll start with Toby.
All right. My name's Toby Eadelman. I'm the Chief Technology Officer at AvaSure. And I come at AI from a little bit of a different perspective, perhaps, which is computer vision. And so a lot of my views today will be flavored probably more by that computer vision side, but AvaSure is specifically related to patient monitoring for adverse events and safety in the hospitals, as well as providing, episodic and video as a platform for hospitals.
That's amazing. All right. Should we call you Dr. Patel? Nick, what do you prefer?
You can call me Nick.
Okay.
Great to be here. I am a physician by training, internal medicine, practiced for over 20 years as a hospitalist as well as primary care physician at Prisma Health, largest health system in South Carolina, but also served as vice chair of medicine and chief digital officer during that time. In the last 2-3 years, I've started Stealth Consulting. So I go around essentially advising large health systems and health tech companies on digital and clinical transformation. I guess my superpowers come from making sure that we focus not on the technology, but really on the clinical need, so we can deliver cost-effective care to our patients. So great to be here. Look forward to conversation.
Perfect. I'm glad we'll have that focus on clinical need, and I'm fascinated by some of the remote patient monitoring potentials. So let's level set for people in the audience. There's a lot of noise about AI right now. I feel like it goes in cycles. Right now, we're on a heavy excitement level. What are common misconceptions that both of you have seen?
Maybe I could start. One of the biggest things I'm seeing, at least from a physician perspective, is that I think a lot of our providers are worried that AI is going to replace them. And we've seen some of that with some strikes that have happened at large health systems across the country. And I think we have to really kind of level set. And I recently actually gave a CME talk to the South Carolina Medical Association and gave a background on what AI is and what it is not. And it was eye-opening for a lot of providers because they've only heard the buzzwords and the hype cycle around it, but they haven't really got to see how it's going to affect their workflow. So first thing is making sure that our providers, that includes our physicians and nurses and everyone in the care team, understand how AI is going to support them but not replace them. I think that's one of the biggest misconceptions I'm seeing.
Absolutely. We've seen the same thing with since we're a virtual nurse provider, we see that a lot on the nursing side, that there's a concern that AI is going to replace nursing and, that critical, judgment that is needed for the clinical judgment side. But another area that I can think of that we have a misconception on there is that we often run across, especially in the area of computer vision, is that an AI installed today is going to remain as accurate over time as it was at the point of installation. And without a ongoing training and adaptation of that model, you're going to have, that fall off over time. And so, making sure that you have a really strong relationship with your AI supplier is going to be critical to making sure to understand how they're going to address that.
That makes sense. I think it's hard because not everybody not everyone understands how it's learning. So it's hard to educate people about why you would need to continuously monitor that and follow up. Let's start talking about things that are working. Like, let's hear some good news. Like, so how have AI-powered documentation support or clinical support tools impacted clinician workload and well-being? Have you seen anything in your organizations or with people that you've worked with? Maybe, Toby, you can start.
So I was going to say, I think Nick probably has a better answer for this one
Oh,
than I do, but
that way he can close it then.
All right, he'll close. Great. So for us, it's we do see a big need for it, especially in the area of virtual nursing, that there's this need for this ambient documentation. And so, we see this need to integrate ambient documentation into our, episodic virtual nursing applications. And so we can see that as a specific, way that this would definitely reduce clinician workload. But I'll let Nick close us off on this one.
Yes.
Yeah, I agree with
Give us the
Toby.
data.
Yeah. So if you look at AMA recently released a document called Operational Biopsy, and it shows that significant burnout in providers, over 50% of providers, no matter if you're 2 years out of residency or 20 years out, more than 50% of providers are burning out. And this is the same thing when it comes to nursing. And nursing also has the complexity of some areas being unionized. And so and the pay rates are still much higher than they were pre-COVID. Agency spend is still pretty high. So when you look at what we do as providers, 90% of the time is have our face in a computer doing documentation. And so, we're looking for data, we're entering data. And one of the things that I think, and I want to kind of zone in on what Toby said on when he said ambient documentation. That is a lot different than the traditional dictation that providers have been using to do their note taking. Ambient dictation allows me, if you're my patient, to actually have a conversation with you and it can understand what I'm saying. Meaning, when I'm asking or saying, what's the main reason you're here? It understands that's the chief complaint. Or let's take a look at that knee. Oh, I feel as I'm talking and I'm explaining to you as well, it looks like you have what we call crepitus in your knee and you have anterior posterior drawer sign, which means that you could have an ACL tear. Right, so you can actually put that under physical exam. It could take what I'm saying and how you're responding to what I'm asking you under review of system. So instead of me actually doing all that, it's doing that for me. Now, of course, it then comes back to me to validate what I wrote or edit and add to anything else I might have thought I missed. But it is actually doing those things behind the scenes. It's not me holding something or me looking at a screen. It's doing that. So it improves the patient and the provider sort of interaction. It allows a provider not to have their face in a computer documenting everything. And so at the end of the day, all those notes are done. They're accurate. And it actually, if have the certain module built in, can help you with coding. So now you're actually leveling up your coding. You're accurately coding and not undercoding. And so you can get to that effective. So there's an ROI that's hard and soft on that. But the other piece is that you're reducing the PJ time, as they call it, pajama time, for our providers who are spending lots of time documenting after they see 20, 30 patients in a day, for example, in primary care. And same thing when it comes to acute care. There's a lot of metrics out there that have shown this. Number one, it's shown that they're closing their notes not 5, 6 days or a week or 2 weeks after they've seen the patient, but more real time, which helps on many fronts because that patient is likely to be seen by referrals and other folks who need to see what they talk to you about. It's allowing for better documentation, which allows for better coding. So there's an actual ROI financially for the organization for that. And at the same time, as AI becomes more prevalent in the systems and larger data sets are being used, it's going to allow for certain care gaps and different things to show up for the provider. So give them almost insights. Hey, based on all the notes that I can read in milliseconds that you can't, I can tell you that based on what you should prescribe this, or this person may go down this path to get to this area. You might want to proactively treat them. And so there's a lot of metrics that I think we're going to see that's going to improve patient care, but also operationally help the health systems.
Yeah. I'm glad you brought that up. Like, that was a great answer. I'm glad you brought up the burnout rates that the AMA has published in their 2024 report. They said, half of you are burned out. And of those people, I think, is it 70% say administrative burden is a major source of burnout.
Correct.
So, and we talk to people in our work too, like physicians, clinicians, they don't want to just be taking notes. Like, they didn't go to medical school to become record keepers. They went there to help patients. And when you're moving from that model where there's just too much work to do and you're, note taking all night, to a more efficient model, like when they're learning about those ambient tools, what are some strategies to make that an easier transition for clinicians? Like, are they just like overwhelmed? How do they learn to trust it? Like, does that overwhelm staff that you've seen, or is that something that is easy? What did you do?
Yeah, I could start with that one. So change management is key. Honestly, it's a huge change to the culture, right? You have to address those myths we already talked about. And so it's critical that you work together with your, AI supplier and vendor, and they can help you with being able to prepare and adjust your culture to the acceptance of AI. Especially, the ones that have had just tons and tons of experience with many hotel or hospital implementations. Another thing is it really comes down to how you implement it. If the AI is implemented as part of an existing interface that they already have, but you're just adding some additional things to it to help, them do their job better, it becomes a much easier adaptation than if you were to make the major shift and there's a whole different interface and you got to learn everything all over again. So making it part of the existing user interface is critical, I think, to this as well. And finally, I think a big part of it is reducing false alarms. A risk with AI is false positives. And so if you just have your AI automatically setting off alarms, you have the risk of creating false alarms. So I always encourage that, especially in the beginning of an implementation of an AI that's going to be setting off alarms, that you have it be the alarms be verified by a human before being activated, unless there's just no time for that particular alarm, in which case you would have to live with the false alarms. But if the time exists, in order to make this a better transition for the caregivers, try to reduce those false alarms.
Mm-hmm. I like that. We can call that the Google it effect. Like, when people would search for things, it's like, you could just have a headache or you could be dying from an aneurysm. I think that's applicable here. Like, you have to learn how to govern that. Nick, do you have any more insight there? Like, how have you helped people?
Yeah, I think trust is the hallmark of a lot of this, right? Yeah, the providers have to trust the technology. And I think that comes with a good partner, right? So tech companies like AvaSure, who have tried and true, track record on these things, are the ones you want to make sure you partner with. So there's a lot of, as I think in the previous session as well, there's a lot of noise around this, a lot of startups saying, quote unquote, I have AI. One is not truly AI, maybe just automation. And so I think trust is number one hallmark. Two, we need to make sure that in talking about those false positives, but it's also important for the false negatives. We don't want to miss something either. And so again, it comes down to trusting the technology and making sure we design it in the right way. And so those are some of the other aspects that we need to think about. But and then lastly, I would say we need to make sure that we try to remove as much bias that may be learned or built into systems so that we're not making the wrong interpretations in certain populations.
Yeah, that's important. Like, if we have biased data, then we're going to have a biased model.
Mm-hmm.
I want to go back and tie that together with something you said earlier about, suggesting a certain course of treatment or suggesting certain medications with AI tools. Like, are they enhancing clinical support, decision-making, and diagnostic accuracy or treatment planning in your healthcare practice? And what does that look like?
Yeah, it can help in a lot of those areas, but people are either at first or second base of that. So we can't use that as 100% interpretation. And the FDA and the payers are not going to let you use AI to make the final diagnosis. It can help you augment and get you the information that you need so you can make a human can make a logical decision, but it won't let you do it without a human intervention. I think that's extremely key. But diagnosis assistance or clinical decision support is extremely important, great use case for AI. There's so much information a provider has to look through to make an interpretation on what the patient's symptoms are, their past is, their genetics, their family history, putting it all together in a way that looks at large data sets across the world, really, to see, look, has similar symptoms like you, same age as you, same gender as you, same maybe family history as you, and what is that going to look like, right? So we can learn from what's happened before. So this is a whole the reason for patient-related outcome databases, et cetera. But we need to take these large volumes of data and crunch it down to a patient that looks like you, because we can't just generically treat everyone the same, because there are nuances, especially rare disease, on how do we use this large population data that we have. So diagnosis assistance for one, for sure, which then reduces time to treatment, which is extremely key, especially things like cancer. Computer vision, as Toby had mentioned earlier. For example, when someone goes to the ER, every single study done in ER is done stat, right? CT scans, chest x-rays, all done stat. Well, the radiologists who are sitting there or remotely are reading them in the timestamp they came in. They're not seeing that, okay, study number 10, actually based on a wet read by the AI computer vision, because they could look at millions of previous CT scans and know what a pulmonary embolism looks like, to say, hey, you may want to look at 10 first. There may be a positive finding. It shoots to the top, notices the pulmonary embolism, and the radiologist reads it faster. So those are certain use cases, pharmacy redesign, risk score adjustment. There's a lot of opportunity to use AI in an effective manner.
Yeah, that would be amazing. I have a friend who had a pulmonary embolism, and they tried to drive them. They asked if they could drive themselves home from the hospital. And they're like, no, we're going to admit you. But
Right.
just seeing how fast that can be, that's a life and death thing.
Mhm.
Toby, do you have any success stories about clinical setting or thoughts on that?
Nick had a pretty complete answer on that
Right?
one. I think, I'll just defer to him on that one.
Yes. So tell me, when you're learning about those things, about the false positives, about false negatives, what are the things people need to know going forward in their clinical practice? Like, what safeguards are we having? Do we have transparency? Like, what's out there?
So I think that that's a great question. When you're looking at AI, you're obviously, in order for it to be useful, it needs to have access to the patient information, and the patient camera, patient audio. And so I think some of the things that you really need to look into is you need to ensure that the vendor has an AI governance board. You need to make sure that they have a very rigorous testing plan. You need to do a security review with your AI vendors, understand what data they're keeping, what security measures do they have in place to protect that data, how often they're doing penetration testing and scanning for vulnerabilities, and are they checking the vulnerabilities at the code level or just at the network level, in order to make sure that all of these things are really being protected.
Yeah, we've seen that. What happens if you don't have enough checks in place? You might have a blue screen of death one day. So the partnership with vendors is more important than ever before.
Right.
Looking forward, if you had a crystal ball, this is the crystal ball section. Like, in the next 3 to 5 years, what do you see? Which AI applications are going to have the most significant positive impact on clinical care?
I could maybe take a shot at that one. The population is exploding and the number of providers are shrinking. It's hard to recruit providers because of the burnout. They're retiring early, et cetera. And so we really need to try to use AI to help us scale care. And that is extremely important, where it can handle population health needs, reduce overall cost of care by predicting early intervention. And that's extremely important. The technologies like AvaSure and others that are doing this are reducing length of stay, reducing 30-day readmissions, so that people are not waiting in the ED or bordering in the ED to get a room. It is also going to be extremely important as we move towards, and most health systems are doing this, moving towards hospital at home, is how do we make the smart home of the future with cameras, mic, speakers, how do those things be used in an effective manner to monitor a patient at home through remote patient monitoring or fall prevention, maybe a house is cluttered, maybe reminding a patient to take their medications, et cetera, because it was noticed that they never opened their pills that day. So there's a lot of opportunity, but for the biggest part, it has to be scalable to handle population health needs, because they're just, I hate to be dire about it, but there are just not enough providers for the growing patient population. Every single day, 10,000 patients become Medicare eligible, and those patients need care. And as we get older, we need more care. I'm not really so much worried about an 18-year-old as I'm worried about a 70 or 80-year-old. And so I think we need to be able to have a lot of more of the AI and ambient technology, not only in the hospital, but also in the home setting. And I think that you're going to start to see that. Just like we're having self-driving cars now, we're going to have technology help us in our environment where we live. Patients don't live in the hospital. They don't live, in a clinic. They live at home. They live in the environment. And that proactive AI monitoring, it's what's going to help a lot of that.
Yeah, I think you're on the right path there, Nick. I mean, the thing that I'm most excited about is honestly the device in every room movement in the acute care environment. Being able to have a camera and a microphone and a speaker in every room allows us to have the opportunity to do ambient AI and to be able to provide a total hospital view of not only the operations of what's going on in the hospital, of meal delivery and how cleaning and bed availability, things like that, but we'll also be able to use AI to detect things about the patients, such as patient mobility. How far are they in their path to recovery, so that are they getting to the point of discharge? So being able to use that ambient monitoring in every room in the hospital, not just the ones that have the highest acuity, I think it's going to be a critical move in the next 3 to 5 years as hospitals adopt this and move in that direction. It's going to be exciting. I'm very excited to see where this goes.
Yeah, Toby, if I could add to that, on the acute side, historically, people have installed cameras in certain rooms, but I think everyone is trying to move towards a smart room of the future. But beyond just telehealth, right? It's not just, okay, we have a camera, mic, and speaker, but now we can use for multiple use cases: virtual nursing, transitional care, pharmacy, education, care coordination. The same system that can actually activate other use cases. And we're doing a lot of this work. The team at Hackensack's doing a lot of this work right now in starting with virtual nursing, but moving into transitional care, pharmacy based on risk, other things that we can use the same set of tools and technology to actually activate other use cases that we haven't thought of before.
Great. I do have, I guess, a follow-up question to that. It sounds like technology will help bridge that gap with a lot of monitoring things that require huge amounts of data. Do you think it will, or how can we design it to support that hospital at home, to support caregivers? Like you said, we don't have enough physicians. We just don't. What do you see as the next steps there?
Yeah, I think there's a couple. Oh, go ahead, Toby.
All right. So I can speak a little bit on the side of acute care. I don't have a whole lot of view into hospital at home, but I'm sure a lot of this will translate into that as well. But a lot of the ability for us to design this to be able to enhance and support the caregiver's role is really going to play into how much the caregiver's involved in that implementation and designing of the AI technology. I think the integration of that, not just providing something that's kind of tossed over the wall, but as it's integrated together, it will be done in such a way where it can be something that's seamlessly provided in the background, and it allows the clinician to continue to focus on their patient, and the AI will be able to help them operate at the top of their license. I think another part of this, so that people need to be aware of, and I think this plays into the hospital at home as well, is that you need to be aware of where the AI is being implemented. Because if the AI is implemented at the edge, you will have a very fast response to what's going on in the camera. Again, I'm speaking mainly from the computer vision side. and the audio. The problem is that you're limited to whatever it was installed with. And so if your whole AI is installed at the edge, you'll be limited in that capacity. Whereas if the AI is provided from the cloud, you will have longer latency potentially, not significantly, but a little bit longer. But you would have the ability to increase the number of classifiers, the number of things that you detect, and the new AI models that can be added. And so I think that provides a lot of, when you're trying to decide which way to go, I think it's critical to look at, where it is located. And then finally, the bias thing plays into all of this related to computer vision as well. And I think we often think about bias in relation to the diversity of the community, but when it comes to model biases, they also are biased by what they see. And so a lot of that even can be, you could be biased by what the training set is as far as like, changes to the equipment in the room, uniform changes, things like that can all cause, model bias. And so you need to be aware of those things as well. That again, I'm kind of harping on the partnership with your AI vendor, but it is critical to understand how you're going to maintain that as the years go on, and that it's not just where the technology is right now, but how are you going to work together to advance that as well.
Yeah, that partnership is critical. Now we opened it up and we have some audience questions. So if you're in the audience, you can comment, you can leave some questions. I'm going to read them. We're going to do it on the spot. Ask your hardest questions for these two. Just kidding, ask good ones. The first one is, when there are cameras in hospital rooms, how can we ensure patient privacy and dignity is protected? And I'm glad they asked this one because that comes up all the time when we're talking about ambient stuff. Like, do we want them listening? What's happening?
So cameras already exist in hospitals.
First of all, that's very quotable.
Yeah,
cameras already exist.
I mean, it's not a new thing. So they're already there, and we are already, working very hard to maintain the privacy and the dignity of the patients. And so that's not really a new thing from that perspective. What's interesting here, though, is that a lot of the ambient monitoring things we've been talking about, there's really two sides of when it comes to computer vision. There is like more of an augmentation type of an AI where you're monitoring for a patient safety thing, let's say falls or elopement. And there's actually an observer that's going to be like monitoring the patient as well. And when it says the patient's doing something, the AI will alert them that something's going on, and they'll look into the room and see what's going on. And in that type of a situation, those people are already, being monitored for those specific things. And so that's not really anything additional to what they were already doing. So the other side of it, which was what we've been kind of calling ambient monitoring, is where only an AI is watching. And in that type of a situation, we aren't really, well, first of all, we don't keep the video. And that's critical. I guess you'd have to check with your AI vendor. We don't keep our video. We run it through the model and it's discarded. So it's not a situation where that video is kept and can be shown to other people. And so that's how we protect their privacy and dignity, is by not having anybody be able to see that. In the situation that there's something going on and that a technician or an engineer needs to look at what's going on with the live video stream, again, it would only be viewed in RAM, and it's gone as soon as they look at it. And those people have already signed a BAA and have been trained for protecting PHI. And so it's a very similar situation to hospital staff, and if they're seeing the employees, or the patients. And so that's how we're able to really protect dignity and privacy.
That's smart. So you don't keep the data. Nick, what do you think? Have you any suggestions for people?
Yeah, I mean, as a provider for 20 years, I've seen all kinds of things that happen in hospital rooms. But again, privacy is a hallmark to everything we do in healthcare. It has to be, right? Both from a regulatory perspective, but also, just from an ethical perspective. And a lot of these technologies do have privacy mode, just like you do on your phone and other things, where you can turn things off. And so we need to make sure that those technologies are usable and baked in. The other thing we have to think about when we install these technologies in rooms is that a lot of the historic rooms in hospitals are dual occupancy already. So they just got a little
Right.
curtain that separates the two patients. And so we need to think about more advanced technologies such as, utilization of the smart hospital bed, which, we can have another whole session on, or directional speakers, and other things. And a lot of technologies now with that computer vision is actually not, you won't see the patient, but in certain privacy modes, because they still need to monitor for fall and all that, but it turns you into a stick figure. And that's all they see. The end person's not seeing you, they're seeing a stick figure of you in moving around a bed, but we're not seeing you changing in bed or using a bathroom in bed. So there are technologies like that are already existing. So again, that's important as part of your due diligence and picking a technology and make sure those features are there. The last thing I'll say is identity management is also important. Is that the person that you're talking to is the person you're talking to, and the person you're looking at is the patient that you're looking at. So validating that as well, because AI has also, as you've seen in the news, used to mirror my voice or to look like me and act like me. And so we have to also be very careful around who the provider is and make sure that they're actually a provider and that the patient is really the patient that the provider is treating, especially when you think about controlled substances, behavioral health, and other things. So there's a lot of things you have to take into consideration.
Yeah, and that actually reminded me of one other thing, Nick, as you were talking about that, which is, a lot of the equipment in the room, like for instance, our equipment, will actually have an indicator when there's a live person viewing as opposed to just an AI. And so that's another way that their dignity is protected, and they can ask for, privacy and things like that. Or if a nurse is in the room and needs to do something, or some other caregiver, they can ask for privacy, and a privacy mask can go on, and the light can be turned off. So that's another great, reminder of how that works too.
That's great. It's important to be able to have that, the privacy. I'm glad those were great answers, by the way, and I learned something. So I'm impressed. There's another question. It says, we've talked about it a little already today about hospital at home. Are you seeing a lot of hospitals implement these programs, and what are the use cases?
Yeah, we even when I was at Prisma Health, I think we're at the forefront there. Started a hospital program when it was just a whisper at other places, and we've seen already readmission rates less than 1%, high patient satisfaction scores, and I think the key is and most health systems when they're doing hospital home, they're thinking about the top 5 DRGs, right? CHF, COPD, those types of things, community-acquired pneumonia, cellulitis. Are some of the ones that most people are looking at, and because those can be handled through remote patient monitoring, camera, and a nurse coming to your home, because the level of care still has to be at the same level it can be provided in a hospital, right? So you're sending home patients who are, stable but need admission and IV medications and close monitoring, but can be done if you have a safe environment to be done at home, and you're going to see a significant increase in this. If this works the way I hope it will, you'll see hospitals become smaller and ambulatory practices become bigger, and that's already a trend because that's where the payers are moving. But it is, and then we can start to use remote patient monitoring, the computer vision, motion detection, and other things that we're using in the hospital, but do it in the home setting. And my recommendation would be, and this is why 30-day readmissions are so low, is you leave the technology behind. It's just a commodity and really not that expensive. And it's most of the AI is a software related, not hardware related. And so when you think about that, those patients who have CHF and other things are going to always have it, right? And so why don't we proactively monitor them so they don't need to go to the ER readmitted? So I think a lot of people are going to start to leave some technologies at home for monitoring of patients with certain conditions.
Yeah. All right. Did you want to add something, Toby?
No,
All right.
we're pretty focused just on the acute care environment. So we hear a lot about hospital at home, and we have lots of future roadmap items related to that. But at this point, we haven't seen a significant movement effectively in that direction. We've seen lots of experiments and things like that, but we just haven't been involved with any of the ones like Nick was just referring to. So
that's great to know what you are doing and what you aren't. One more question, and then we'll, predict more of the future. you talked a little bit about technology as a commodity and then contrasted that with like the importance of having an AI partner that has continuous monitoring. Do you feel like those contradict each other, or how do you find balance in those spaces?
You want me to take that, or Toby?
Yeah, go ahead. You can start.
Yeah, I think they go hand in hand. Remember, AI is not a singular thing. Speech recognition, natural language processing, deep learning, robotic process automation. There's a lot of things. If you think about AI, it's really kind of like humans, right? I mean, that's where we want to go. And humans learn through looking and learning and reading. And that's how AI will eventually do that as well. But you cannot look at AI in a vacuum as one particular tool. It needs to have all these other components. For example, we talked about documentation. Well, that's great, but if you actually wanted to do certain functions like triaging and note taking and also handling your inbox, you need robotic process automation as well. So it's a combination of tools that will learn to get to that level of PhD expert level, for example. And I think that when you look at technologies like AI, we need to understand how it's going to fit in the workflow of the patient, of the providers, as well as how it's going to affect the patient. And this is why I think you have to be very cautious as you implement these technologies and bring them on, because you need to really do focus, again, as I'm always going to do, is focus on the clinical need and making sure the technology is married to that need. And I think if you do that, then you will have less of that contradiction and you'll have more effective use of it.
I like that.
So, on that note, I absolutely agree that it needs to be able to be a situation where, the different AI models are going to coordinate and work together more in the future. You're going to be looking at multiple classifiers working together in order to be able to detect more complex actions and situations. I think one of the challenges that, I used to work in automotive. I was very involved in the early days of voice recognition. And, as we were starting to, put functions into the car for voice recognition, we ran across a situation where, one of the requirements we had received from the car makers was, hey, we want to be able to use voice commands to turn on the headlights. We end up using commands to do 5, 6, words to be able to, hey, car, please turn on headlights bright. And it would have just been a simple flick of a button. And I think that's one of the challenges that as we look forward, and this is why, again, partnership is critical. When we look at the use cases that are most important, is we need to make sure that AI isn't being implemented in situations where it's easier for a human to do something that the AI is being put into place for just because the AI exists. And so by really working together and identifying where is the pain points and how can we address those pain points in the hospital environment, I think that that's really a critical look that we need to look at in relation to AI.
Well, thank you. I think that I love that perspective, just to bring it home, thinking about creating something in partnership with technology and clinicians to improve patient care, to reduce burnout, and meet the clinical needs that we're going to have in the future and that we have today. I want to thank you both for your time today, and thank you for coming here and sharing your insights about AI and your work.
Great. Thank you.
Thank you.
I echo that. Thank you. Thank you so much. And Janae, you're going to be sticking around here. Yes, you are. Hello. I'll be right back to you in a second. Yeah, we're going to be wrapping up here.